Welcome to Expert Perspectives. I am Morton Coleman, Director of the Center for Lymphoma and Myeloma at Weill Cornell Medical College, and we are here at Lymphoma and Myeloma 2014, an international conference on hematologic malignancies. With me I have Dr. Ruben Novitsky, who heads up our myeloma section and has done a great deal of work in the research, both from the basic science as well as the clinical aspects of multiple myeloma. Welcome, Ruben. Ruben, tell me, what did you find in the conference that was the highlight in terms of basic science? What did you glean from the many speakers that we had, giving us some very exciting and new information?
Indeed, the meeting was very exciting, and we had speakers from every area on the multiple myeloma research. We had basic science, translational science, and we had significant clinical advances discussed. From the perspective of the basic science and translational science, we had a lot of information about genomics. Interestingly, the gene expression profiling in myeloma, which had to be one of the top ways that we can predict responses and outcomes, appeared not to fulfill that hope, as it fails to identify patients who achieve a CR in 40%. Therefore, new techniques are required. It was recognized that whole genome sequencing and exome sequencing would be perhaps a newer pathway to establish prognosis and discovery in myeloma. The surprise is that similar to other tumors, the myeloma has many mutations and alterations in the genomic basis, as is very difficult to pinpoint a specific translocations or mutations, deletions that can predict therapeutic pathways.
From a clinical perspective, we can then assume at this point that genomics has not yet replaced FISH as the clinical means by which we can try to prognosticate certain patients. Would that be correct?
It was discussed that, in fact, we need to use the three global arenas to be able to prognosticate. We have to use genomics, we have to use FISH, and certainly we have to use the clinical aspect, including the staging, beta-2 microglobulin, and the protoplasm of the patient.
What suggestion would you give to the clinician out there who says, what should I order for my patient right now to help me in making a decision on how to treat him?
Well, the patient has to be looked at several dimensions, and certainly at this point some groups are including the expression profiling as part of the prognostication, but that's not being widely used. Most of the groups agree that with defined probes by FISH, in interface FISH, done through selective techniques such as CIG or selected plasma cells through columns, we can identify better prognosis in those patients. The problem also is that not every group is doing FISH in selected cells.
We heard some very fascinating debates at the meeting. One of the debates was whether one should treat smoldering myeloma or whether one should not treat smoldering myeloma, or whether we should be selective in whom we treat. How do you approach smoldering myeloma at this time, especially in light of what you heard at the debate?
Smoldering myeloma is a gray zone group of disorders. We cannot just identify one. And there are several factors that one has to consider in initiate therapy or identify those patients who will progress. If you look at smoldering myeloma, the progression rate at the first 5 years is almost exceeding 40%, and as the disease evolves, the following 5 years, the progression plateaus. To that point, we say that the first 5 years, it will identify patients who are not really smoldering, but they should be called myeloma in evolution. So if we can identify those patients by biomarkers, we will be better in defining which patients will require therapy. Several models of progression have been identified. The ultra high risk smoldering are those patients who have a free light chain ratio of more than 100 or a bone marrow plasmacytosis of 60%. And in fact, the International Myeloma Working Group has identified this as a subgroup of patients that should be called active myeloma and initiate therapy. So that's been a shift on the approach to patients with smoldering. Now, there is another subgroup of patients that we call them smoldering myeloma with high risk features. And it's not a consensus whether you should treat those patients. Certainly those patients should be candidates for clinical trials similar to the one by the Mayo Clinic or the group in Spain, which has actually published the use of lenalidomide as delay for relapse and some advantage in survival.
Yes, would you like to comment on maintenance therapy? What role should it play? What should we use for maintenance therapy after a patient has received an autologous stem cell transplant? Do you use maintenance? Is your use of maintenance based on the depth of the response? And which drugs do you use?
Well, maintenance has been established post-transplant through several clinical trials, initially through thalidomide-based, and before that, other less effective regimens. The problem of thalidomide as a maintenance drug is that the toxicity precluded the use of it in about 60% of the patients. So there was a great deal of discontinuation of those patients. And therefore, with the advent of lenalidomide, which is better tolerated long-term, trials have shown that the post-transplant, there is a delay in relapse with an increase in progression-free survival. And one of those trials has shown overall survival advantage. And therefore, the common opinion is that patients post-transplant should initiate maintenance with long-term lenalidomide. However, the one trial had to suspend the use of lenalidomide long-term and suspended at 1 year, thus failing to achieve the best responses and the long-term outcomes. Therefore, there is still some school of thought that want to limit the use of long-term maintenance or select patients who will not necessarily benefit. By utilizing sophisticated minimal residual disease approaches, those can be perhaps identified, and therefore patients who are MRD negative might not be candidates for maintenance therapy. That's still up to discussion, and we are awaiting large studies both in Europe and the United States that will address those questions.
Yeah, I believe one of the European studies showed that maintenance Rituxan really was better if you just kept it on an unlimited basis as opposed to a finite duration. But what I'm curious about is whether you have concerns about the development of myelodysplasia and leukemias in those patients on lenalidomide maintenance who had exposure to alkylating agents, particularly alkylating agents used in transplantation. I know you have a great deal of experience with no limited duration of your BIRD regimen, which does not seem to have leukemia associated with it. Would you comment on leukemia genesis of lenalidomide following transplant and exposure to alkylating agents?
Several studies have shown that there is an increase in the development of secondary malignancies in people receiving lenalidomide. However, it has not been well dissected to what extent the other factors play a role on the development of these complications. Indeed, when lenalidomide is used in combination with alkylating agents, as in the non-transplant candidates, there is an increased frequency of myelodysplasia. And therefore, it generally is not recommended to combine lenalidomide with alkylating agents. However, there's something about the sequence, because if you use lenalidomide and then the alkylator, or the alkylator and then lenalidomide, the frequency of these conditions may change. For instance, in the context of transplant followed by lenalidomide, there is a slight increase on the MDS and AML, but mostly in those groups who receive intensive chemotherapy and alkylating therapy before. Hence, the responsible for these conditions is the heavy alkylator therapy.
Do you think the data on the proteasome inhibitors are sufficiently mature to want to consider using them in maintenance as a replacement for lenalidomide, or even perhaps in combination or in sequence? What is your opinion on using proteasome inhibitors for maintenance?
The use of proteasome inhibitors as maintenance has been explored at least in 3 different schedules. There is a schedule that is weekly, 4 out of 6. There's another schedule that is every 2 weeks. And there is another schedule with syncopated full cycles of bortezomib on days 1, 4, 8, and 11 at 2 to 3 month gaps. None of them has shown superiority over the other, and none of them actually have been studied prospectively against each other. So we don't know which one is superior, and we don't know which bortezomib regimen in maintenance is superior to other alternatives. So there is still required to do studies long-term in the maintenance therapy. However, those studies will never be done, because now there is at least 2 proteasome inhibitors which are oral that appear to be more amenable for the use in the maintenance programs. Those are ixazomib and oprosumib, and therefore we will start seeing trials exploring maintenance with oral proteasome inhibitors, and we hope that we can start designing therapies in combination with lenalidomide. There is a subgroup of thought leaders who think that patients who have high-risk myeloma, for instance, 414, 1416, or deletion 17, will benefit of maintenance of both lenalidomide and the proteasome inhibitor. And although there is no randomized data to prove that, many of them have incorporated this type of programs in the maintenance setting.
Now, one of the major areas of controversy, and we had an excellent debate at the conference, was on the necessity for achieving minimal residual disease, however strictly defined. Would you comment on how we should determine minimal residual disease, and what do you think? Should everyone be brought down to minimal residual disease, or should selective patients be brought that way? How do you feel we should use our current capability of determining this in the management of patients?
Well, during the lymphoma myeloma meeting, important set of data was provided by the speakers, substantiating the fact that patients who achieve deep, sustained responses will have better outcomes in terms of overall survival and progression-free survival. And therefore, I think that it's quite clear that patients who achieve this type of responses, and those responses could be sustained, will have the best benefit. True also is that the concept of complete response is changing as we improve our ability to detect minimal residual disease. And therefore, we We started by using free light chains as the best technique. Then we switched to immunohistochemistry. Now we jump to flow cytometry and even molecular techniques. And now we can detect 10 to the 4 as minimal residual disease tumor burden. Perhaps at that time we will be able to define better what does really complete remission mean and how to define therapies depending on the achievement of those.
At this point, do you try to achieve MRD in all of your patients or in some of your patients? So what message should we give to the doctors practicing outside of a major medical center?
There is quite substantial evidence achieving complete response both in the transplant setting and in the non-transplant setting that there is benefit for achieving that type of response. It's not only the achievement of the complete response, but the sustained maintenance of that complete response. So yes, I ascribe to that concept of trying to achieve complete response, albeit trying to adjust for toxicity in the elderly and frail patient with more aggressive programs for the younger and more fit
but I gather from what you're saying that the elderly frail patient is less a candidate for MRD achievement than you would a young patient who's fit and otherwise fit and who could handle the medication. I mean the approach.
And yet by utilizing the therapy in a judicious way, for instance, using the bortezomib at a lower dose, in a better schedule, in subcutaneous administration, can deliver better dose intensity long term and achieving those type of responses as well. So it's not necessarily that the elderly will not be able to achieve that, it's that we have to learn better how to treat those patients.
One of the issues that came up is, should everyone get transplanted who's capable of undergoing such rigorous therapy? Do you believe in doing transplantations at initial therapy, or would you withhold the transplant until you feel the patient is getting resistant to whatever your new combination may be that you were administering?
I think the consensus is that the transplant is not the goal. The goal is complete response, and if you can achieve that complete response without transplant, then you can forego or defer it for a salvage setting. However, that has not been proven through clinical trials, and we're awaiting the results that we're going to answer that question.
I understand. So what are your favorite regimens for initial therapy in the fit patient, not the fragile, high-risk patient with a great number of comorbidities?
Several induction regimens have been designed, instead of telling you which is a favorite regimen, I would tell you the favorite goal is to achieve a CR rate of more than 30%. You should reject anything that gives you a CR rate of less than 30%. So regimens that achieve that, in general, are the triplet of bortezomib, lenalidomide, and dexamethasone, or the triplet of cyclophosphamide, bortezomib, and dexamethasone, or our own Biaxin, Revlimid, and dexamethasone. Now, there is data of a new regimen based on our own phase 1 and phase 2 data, in which carfilzomib is combined with lenalidomide and dexamethasone, and that has an increased CR rate. So we hope that by increasing the tolerability of the proteasome inhibitor in combination with these agents, we will be able to achieve that type of results.
How about how do you approach the patient who is not transplant eligible? Do you still think there's a role for melphalan in their therapy?
There is a role for melphalan in the adequate combination. So bortezomib, melphalan, and prednisone is a good combination with very good track record and very well evidence-based superiority over melphalan and prednisone. There is now ongoing studies comparing carfilzomib, melphalan, and prednisone to control arms, and therefore I think melphalan, as it stands alone, is not sufficient, but in combination is still an effective regimen. The problematic is that there is a lot of nuances on how to deliver melphalan, and there is a problem of bioavailability, monitoring, etc. So not every patient can receive properly dosed. And that we have seen, for instance, in our own upfront trial, in which we can compare a doublet of bortezomib, dexamethasone against bortezomib, melphalan, and prednisone, or even bortezomib, thalidomide, and dexamethasone, and we saw no difference in the three arms. And therefore, I think in the elderly, frail patient, a doublet is as good as the melphalan-containing regimen.
Would you care to comment on data generated with just lenalidomide and low dose, what we call low dose dexamethasone, which is maintained? Would that be as good as using the alkylating agent itself?
A recent trial has compared the use of lenalidomide and dexamethasone versus lenalidomide and dexamethasone continuously versus melphalan, prednisone, and thalidomide. And the winner was lenalidomide and dexamethasone, but not by virtue of the responses or initial tumor debulking, but rather by the continuous use of lenalidomide as maintenance, which was not used in either of the other two arms.
Well, my understanding is it's difficult to use melphalan for more than a couple of years, since there's a fairly high incidence of myelodysplasia and leukemia. And I think many of the programs that tested the combinations of melphalan with the novel agents actually stopped the melphalan after a defined time.
Absolutely, but in this program, the first trial is called, which was led by Thierry Facon of the French group, only looks at MPT, melphalan, prednisone, thalidomide as a control arm, and suspends the thalidomide at month 12, whereas he could have continued thalidomide as maintenance and see if, in fact, the maintenance with lenalidomide reflects a superiority over the maintenance of thalidomide.
Well, thank you very much, Dr. Novitsky. We very much appreciate your perspective on the first day of the Lymphoma Myeloma 2014. Dr. Morton Coleman, wishing you a good day.